I'm basically going to give a very clear outline of what diabetes is, why does it matter if we don't control it well, and can we prevent it. Often, as medical technology gets more sophisticated, we kind of lose sight of the basics. And we want new technology, which is fine, but we need to take care of the basics. And I think the first thing that people need to really have a good understanding of, what is the diagnosis or definition of diabetes? It comes in a variety of flavors, but the essence of all diabetes is it's an abnormality of blood sugar. The true definition is a fasting blood sugar of 126 or higher, a non-fasting sugar of 200 or higher, or an A1C higher than 6.5. An A1C test is a measurement of how much sugar is stuck on your blood. And what it does is it gives us an idea of what your blood sugar has been running for about a 3 or 4 month period of time. So if your fasting sugar is over 126, or a non-fasting is over 200, or an A1C is over 6.5, you have diabetes. But diabetes is a lot more complicated than just a sugar phenomenon. Diabetes is really a metabolic problem. It has an adverse effect on blood pressure, cholesterol, fat metabolism, inflammation, and a whole host of other things. But everybody's familiar with the sugar business. The reason I think the definition is important is it's amazing how many patients that I have that if you ask them if they have diabetes, they'll say, wait, just a little bit. It's like being a little bit pregnant. You either got it or you don't. And if you don't understand that you have it, then you may not take care of all those other variables that are important at keeping the disease at bay. So it's important that if people have diabetes, they understand that I have diabetes. It may be very well controlled from a sugar standpoint, but I still have diabetes, and there are a lot of other things that I want to look at other than sugar. So when we look at that definition, we say, how do I know I have diabetes? You know, a lot of people will come in and say, you know, what are the symptoms? Diabetes is like every other disease in that early in the disease process, the most common symptom is nothing at all. You know, people will say, I'm going to the bathroom like crazy, I'm drinking like crazy, I'm thirsty all the time, my weight's dropping. If they have diabetes, they've probably had that for at least 5 years. Long before they had symptoms, they could have met the criteria for being diabetic and just didn't know it. And that's part of the problem, because all those other things like vascular disease and all the bad things you hear about diabetes are in process early on. So don't rely on symptoms to tell you if you've got a problem or not. And your basic blood work screening can pick this stuff up. Other things that might be helpful, because you can be a diabetic with a normal fasting blood sugar. Other things that might tip your hand as to whether you're at risk, are you overweight? A lot of people get into discussions about what's really overweight. Well, an endocrinologist I trained with said, you know, if you walk in the room and the first thing I see is your stomach, you're overweight. You know, 10 pounds, 50, it doesn't matter. If you're overweight, check one. If you have high blood pressure, and what's high blood pressure? Well, for a diabetic, 135 over 85. For everybody else, we say 140 over 90. Why? Well, because in the 20s, an insurance company found out that trying to insure people with blood pressures higher than that was a high risk. So 140 over 90 must be normal. Well, not really. We're changing that. But for diabetics, if you're at 135 over 85, you're overweight, you got 2 strikes that are putting you in that diabetic category. If your good cholesterol, or HDL, is low, that's a big red flag, because cholesterol metabolism is regulated by insulin. And typically what you'll see is a low HDL and a high triglyceride. Triglycerides are your blood fats. If your HDL is below 40, your triglycerides are above 200. If you have high blood pressure and you're overweight, by definition, you have metabolic syndrome, which is pre-diabetes, and we haven't even looked at your sugar yet. So when we look at diabetes, we need to think of the body as a whole. We need to stop looking at all these little different elements as separate entities and say, what do they all mean as a whole? So if you go to your doctor and he says, look, you need to lose some weight, your blood pressure's up a little bit, your triglycerides, I'm not really too happy with them. You know, one of the things that you need to say is, well, am I at risk for diabetes? Because based on those criteria, you are. And so you need to step it up. If there's a strong family history of diabetes, mom, dad, brothers, sisters, again, that puts you on a higher rate because we know that diabetes, especially type 2, runs in families. Ethnic variations, African American, Native American Indians, Hispanics, higher risk of diabetes. So when you piece all that stuff together, that's the kind of thing that you want to start mapping out early, because early aggressive treatment is the key to success. So you go in and, again, fasting blood sugar of 126, a non-fasting sugar over 200, an A1C over 6.5, that's it. Why is good control important? A lot of times in medicine, we do things and we have goals and we say, okay, you're putting me on all this medicine, but what am I going to get out of it? And sometimes it's hard to really show some tangible evidence. We give things for people with restless leg syndrome and you hope it helps and you hope it works. People with mood disorder, and sometimes it's really hard to measure something. With diabetes, the number one cause of death in this country is heart attack and stroke. Number one cause of death in a diabetic is heart attack and stroke. If you look at that A1C value, with every 1 point drop of that A1C, you lower your risk of all-cause mortality by about 25%. You lower your risk of blindness by about 25%. Kidney failure and dialysis by about 25%. So getting tight control of that sugar pays off. But that's not the only thing that we have to focus on. Controlling cholesterol. What's good for one person isn't necessarily good for another. If you're a diabetic, the goal of LDL, or bad cholesterol, is to get it as close to 70 or lower as you can get. That's hard to do, and I can guarantee you there's not too many diabetics out there, or non-diabetics, that have a LDL at 70 already. So you're going to talk about putting on therapy for that. Looking for protein in the urine. Sometimes the first sign that the kidneys are getting dinged by the diabetes is seeing protein in the urine. You're not going to have any symptoms. You got to look for it. But if we put somebody on a blood pressure medicine, a specific blood pressure medicine, we can reduce the amount of protein in that urine and reduce the risk of kidney failure substantially. Blood pressure, 135 over 85 or lower. And tight control of blood pressure is as critical as controlling your blood sugar, your cholesterol, and everything else. So getting vigilant about getting those numbers under control, our goal is you live longer, you live healthier, with a better quality of life. A lot of times it requires a lot of medicines. Medicines are expensive, medicines have side effects, and a lot of people aren't happy when you start getting into this pill salad routine. I need something for my cholesterol, I need something for my triglyceride, I need something for blood pressure. Sometimes it may take 2 or 3 different blood pressure medicines to get your pressure under good control. Then we got to start talking about what diabetes medicines do we use. There's metformin, there's Actos, there's the new class of drugs, the incretin drugs like Januvia and Byetta. There's the sulfonylureas, there's insulin. I mean, there's a virtual smorgasbord of drugs that we can use out there. The key is we want to get good control, because when we do, you substantially reduce the adverse effects of diabetes. Once you've crossed that line and you talk with your doc and you talk about the different therapies that you want out there, and that we could have a whole nother conversation on how all that stuff works and what works better than others and who works best with each other. Even before that is, can we prevent it? I mean, I would much rather not have diabetes than have well-controlled diabetes on a whole bunch of medicine. And the good news is we can prevent diabetes. How do we know if somebody's at risk for diabetes? We go back to that classic metabolic syndrome parameter. Metabolic syndrome and pre-diabetes are one and the same. How do you know if you have pre-diabetes or metabolic syndrome? It's a combination of elevated blood pressure, being overweight, low HDL or good cholesterol, high triglyceride, and a high but still normal fasting blood sugar. If you have that constellation, you have metabolic syndrome. Why is that important? Because a metabolic syndromer has about an 8 to 10% risk of converting to diabetes yearly. Rough estimates, about 1 in 4, 1 in 5 adults meet the criteria for metabolic syndrome. Worse, about 1 in 8 school-age kids meet the criteria for metabolic syndrome. And we're seeing an explosion of prediabetes and diabetes in teenagers and 20 and 30-year-olds. If we go back to the different variations of diabetes, you got type 1 diabetes, which is basically, I'm not making insulin. Very few of the diabetics have type 1. About 5% of all diabetics are type 1. We don't know why it happens. You just don't make insulin. The vast majority of diabetics are type 2 metabolic syndrome driven. These people are insulin resistant, and that's what sets the stage for it. And if you can identify these people before they progress to overt diabetes, there are things that we can do to change it. We can actually stop the progression. Now, when we look at this stuff, some people are not too familiar with metabolic syndrome, but it's been around. When I was in medical school back in the 90s, it was called Syndrome X. We didn't know exactly what it meant, but there was a very hard correlation with Syndrome X and diabetes. We didn't really know that Syndrome X, which became metabolic syndrome, is prediabetes. Now, the Joslin Center just kind of has put this out. 54 million people right now have prediabetes. That means those 54 million people, approximately 10% of those are going to convert to diabetes every year. If you look at metabolic syndrome, well, this is back in 2005. It's in kids, and it's becoming an epidemic. So it's been around. This is an article that was published back in 2004 calling metabolic syndrome time for action. And here they go so far as to say that metabolic syndrome will overtake cigarette smoking as the #1 risk factor for heart disease. You see it in this, and you see it all over. So metabolic syndrome is not new. We're just understanding it better, and we're completing the picture. So how do we treat metabolic syndrome? First and foremost, lifestyle. And if you don't think lifestyle works, look at the Pima Indians in southwestern United States. The Indians on a reservation, more than 50% of the adult men have type 2 diabetes. You look at the same Pima Indians in Mexico, less than 8%. Genetically, the same group of people. It's lifestyle. We look at the explosion of insulin resistance, metabolic syndrome, and prediabetes in adolescents, 20 and 30-year-old. The #1 cause is not that there's been some gene shift or some genetic shift. It's our lifestyle has changed dramatically. So the first thing I tell people when I see that they have this is I tell them, you have metabolic syndrome. And if we do nothing, your risk of converting to overt diabetes is about 10% every year. I want them to leave my office understanding that. A lot of times people will leave the office saying, well, my blood pressure could be better, my weight could be better, my cholesterol's off a little bit. But unless you tie it together and make that declarative statement, people are still under that impression that it's not that big of a deal. But if you say this is pre-diabetes, and if you don't do something, you will at some point early become a diabetic, they're going to take it to heart. First thing you do is you look at the diet. You do not have to reinvent how you eat. A lot of people will get into carb counting and just completely get so flustered. Basically start with the big ticket items. If you started the day off with a Mountain Dew and Twinkies, you're doing it wrong. And you don't need a nutritionist to tell you that. Cut out the junk sugar. Cut out the excess sweets and stuff. That doesn't mean you can't have a piece of cake. It doesn't mean you can't have pancakes once in a while. But if you're having that kind of high sugar load every day, it needs to change. The complex carbohydrates like potatoes, rice, pasta, starches, they're not your enemy. But if you're going to have a baked potato, don't have a side of rice and macaroni salad. If you're going to have a dinner roll, have one. Don't have 3 or 4. Smaller portion sizes. Most importantly, exercise. 30 minutes of walking every day can lower your risk of progression to diabetes by more than 60%. There's been several studies done in Europe, a couple done here in the United States. Physical activity is the magic bullet we're looking for. Get walking. Some people feel that if I can't work out strenuously, if I can't go to the gym and work out for an hour, I'm not going to get any dividends. You're dead wrong. 30 minutes of a decent walk every day can lower your risk by almost 60%. There are medicines out there, and the latest one is Actos, which I'm a big fan of, and it did a trial called the Act Now trial. And it took metabolic syndromers, and it showed almost an 82% reduction in preventing the progression to overt diabetes. So there are medicines out there, but lifestyle is where you want to start. So when you think of diabetes, when you think of what I need to do to live long and healthy, get back to the basics. Don't smoke, don't drink to excess, eat balanced. Some people really stress about how to construct a new age diet program. You can eat anything and everything you want. Look at a lot of these Western countries around the world that don't have nearly the problems that we do. Why? They're eating fat, they're eating butter, they're not eating as much, and they're more active than we are. So get back to the basics. Don't rely on medicines to fix everything. If you have strong family history, if you have abnormal values like cholesterol and things like that, sit down with somebody and say, what is this? Are all these little things we're treating separate entities? Or do I have something called metabolic syndrome? And am I at higher risk for type 2 diabetes? It's important to kind of nail that down, I think, because I think it does motivate people more to get more serious about what's going on. If you look at your blood pressure and you say, well, it's 140s, that's not too bad. If you look at blood pressure starting at 120 over 80, every 20-point increase in that top number doubles your risk of heart attack or stroke. So you go from 120 to 140, you just doubled your risk of heart attack or stroke. You go from 140 to 160, you double it again. It's that important. Cholesterol is important insofar as what are the other related factors. Vascular disease is really a disease of inflammation. And there was a recent study called the Jupiter trial that looked at supposedly healthy men with normal cholesterol. And they put them on a cholesterol-lowering drug. Lo and behold, there was about a 50% drop in relative risk of heart attack. Why? Is it because cholesterol is that damaging? Well, these people also had an elevated C-reactive protein. C-reactive protein is a molecule that the body makes in the presence of inflammation. And in certain levels, it's highly associated with vascular disease. Well, all these people had elevated CRP too. So who did what? What population across the board has elevated C-reactive protein? Pre-diabetics and diabetics. And we know that cholesterol medicines lower C-reactive protein. That's been known. This isn't nothing new. What would have been interesting is they took people with normal cholesterol and low or normal CRP and see what happens, but they didn't. Obesity gets a lot of negative press in the sense that sometimes we're felt to believe that obesity led to my diabetes. It led to my hypertension. I tell people to turn it around. Your insulin resistance led to your obesity. Insulin resistance causes changes in how you metabolize fat. Fat, we used to think, just sat there and didn't do anything. But fat produces a lot of hormones. It does a lot of communicating. One of those hormones is something called adiponectin. And what adiponectin does is it helps the body direct where fat goes. Normally, you do not want fat in your organs. If your adiponectin levels drop, your fat metabolism changes. Your triglycerides go off kilter. You start accumulating fat in organs. One of the most telling consequences of that is that fat in the liver, because of fatty infiltrate, is probably responsible for more cases of cirrhosis or liver failure than alcohol. Who has low levels of adiponectin? Pre-diabetics and diabetics. Who has a very high level of fatty infiltrate of the liver? Pre-diabetics and diabetics. A lot of times, what does your doctor tell you to do? Lose weight. Well, it's not necessarily based on the weight, it's because of how your body metabolizes fat. Things like inflammation, C-reactive protein. Things like clotting. Diabetics are a higher risk for having high levels of PAI. PAI is an inhibitor of something that helps us dissolve clots. Other factors that play a role in blood pressure, like nitric oxide. Diabetics have low production of nitric oxide. Why? because for some reason, insulin regulates another molecule called asymmetric dimethylarginine. That blocks nitric oxide synthase, which inhibits your ability to make it. Who cares? Well, nitric oxide plays a key role in relaxing arteries, keeps your blood pressure decent, fights infection. So when you look at diabetes, it's really a whole body process. And I think early intervention, identifying those people at risk, is absolutely key. And being aggressive. And aggressive in most people may be just get moving. Start a walking program. Look at what you're eating and clean it up a little bit. Some people come in and they're drinking 6, 7 sodas a day. You know, it's too much. Whether you have metabolic syndrome or not, it's too much. People are eating fast food. They're on the go. I don't have time. You know, we have to make time, because if we don't, we're going to see, and we are seeing it now, an explosion of type 2 diabetes in younger people, which means they're going to be having those complications in 40s, 50s, and 60s. And it's really going to cause a real problem on how medicine is doled out. Stuff's expensive, but nothing's better than prevention, and lifestyles do help. When it comes to treating diabetes specifically, there's a lot of different stuff out there. If you go back to the physiology or the defect of why you're a diabetic, that's helpful. If you're a type 1 diabetic, it's easy. You need insulin because you ain't making it. If you're a type 2 diabetic, it's mainly because, one, you have insulin resistance, but you also have something called beta cell failure. Beta cells are the cells that make insulin. And what we know over time is that the ability to make the insulin that we need starts to wane. And when the insulin levels start to drop is typically when the blood sugars shoot. That's typically when people come in feeling poorly, urinating a lot, thirsty all the time. But by the time you've reached that point, you've lost approximately 80% of your beta cell function. By the time somebody is insulin resistant, you've lost about 50% of your beta cell function. So if we're going to treat a diabetic, especially early in the disease, the two things I focus on is making somebody more insulin sensitive and preserving the beta cell activity. And that's how I gauge therapy. What agents do I use out there? Well, there's insulin sensitizing drugs like Actos, Avandia. Metformin has some insulin sensitizing drugs, but metformin's key action is to really turn down your body's production of sugar. The incretin hormones are getting a lot of excitement. There's Januvia, which is a tablet, and Byetta, which is a shot. And the incretin hormones are hormones that the gut releases when we eat something. And they help us produce insulin when we need it, help us lower our production of sugar when we don't need it, slows our gut so it doesn't empty so fast, but it also seems to preserve the beta cells. And so if we get people early in the disease, when they just make that crossover, lifestyle, absolutely number one. But if I see people continue to progress, I get them on insulin sensitizer. I'll get them on metformin as well. I'll get them on a little Januvia or Byetta, all three of them, because all three are working in a different area. And what we're looking for is not only a good looking number in 6 months, but have a good looking number in 10, 15, 20 years. Because if you get diagnosed with diabetes at age 35, you know, hopefully you're going to be around till you're 70 or 80. And it's going to be easier if we can preserve what function you have and make the body react more physiologic, make your body utilize the insulin you're making more effectively. The only time I go to insulin is when you need to. If you're not getting the sugars you want and you're on the oral medicines, do it. There's a lot of people that are starting to look at using insulin early, even before some of the oral agents. Somebody comes in and you think they're just crossed the border, put them on a once-a-day long-acting insulin for 2 to 3 months, and then stop it. And a lot of times you find that everything is normalized. That's not really that new. Back 20, 30 years ago when insulin first came out, longer than that, you would have what we call a honeymoon phase. You put somebody who's really poorly controlled, you put them on insulin, you bring their sugars down, suddenly their sugars start going lower without adjusting the insulin. They keep going lower, you start pulling insulin away. Suddenly you stop the insulin altogether and suddenly they're normal. What happened? Well, the body kind of adapted a little bit. When your sugars get too high, your body develops glucose toxicity, sugar shock, and the pancreas just kind of shuts down. You lower that sugar with insulin and you'll see some pancreas function come back and you'll actually see things normalize for about 6 months to a year. But again, The insulin resistance is progressive, the beta cell failure is progressive, and you'll see things kind of slide out again. So it's a short-term fix, but it's an option out there, and using it in combination with everything. But I can't emphasize enough physical activity. You know, I mean, with my kids are 12, 14, and 16. They don't have gym class all year long. You know, they take it for, you know, half a semester and then they're done. And I think that's a real problem. Your kids don't have to be athletes. They don't have to be on sports teams, but you want to get them exercising. You want them to have that component so when that they're out of school, they do have that kind of lifestyle, that they do go for walks or bike ride or whatever. But in school, some kids go through the whole year and they don't have any gym class at all. So as you go through it, things are changing. There's new and exciting medicines on the horizon, but what's even more exciting is the prevention strategies that we're seeing, not only with lifestyle, but with certain medicines. And I think if we can prevent it, we're ahead of the ball game. How do we prevent it? We need to have more awareness of it. And I think we really need to have to understand what this metabolic syndrome means and what it implies. We got to stop looking at all these variables as separate little entities, and we need to cluster them together and say, this is what it is. Now we got to hit it. So with that, I'll zip it.